go. Okay, good morning, everybody. The time being 10 o'clock. We'll open this morning's hearings and recognize the prime sponsor of the first bill, Senator Prentice. Good morning.
Good morning, Senator Bradley and members of Senate Health and Human Services. For the record, my name is Sue Prentice. I'm the state senator from District 5, the Connecticut River Valley, a beautiful part of New Hampshire and on the Vermont border. I'm here before you today to introduce Senate Bill 407, which we call the Healthy Moms and Healthy Babies Act of 2022. This legislation would amend the state Medicaid plan to provide 12 months of continuous coverage for new mothers at a most vulnerable time, the postpartum period. A group of New Hampshire moms become eligible for Medicaid coverage under what's known as a pregnancy pathway, and that follows them through the 60 days after giving birth. This group, due to their income, which is 196% of the federal poverty level, are not covered under the granted advantage. We have the opportunity in New Hampshire to cover these mothers for a full 12 months after giving birth and to take advantage of federal matching dollars that are available through the American Rescue Plan. Dr. Emily Baker, and I have testimony from Dr. Emily Baker and Dr. Ellen Joyce, both who have worked on this bill with my colleagues and I. She actually, one of the key points that I'd like to make was raised by Dr. Baker. She's a high-risk obstetrician from DHMC. She shared that the Maternal Mortality Review Board in New Hampshire has found what is absolutely clear across the nation, that the numbers of maternal deaths are increasing, and the majority of maternal deaths that are pregnancy associated occur during the postpartum period. The vast majority of these deaths are preventable. The rise in postpartum deaths correctly infers that there is also an increasing burden of medical and psychiatric morbidity that needs to be addressed and can only be addressed when women have access to health care that they can afford. In the state fiscal year 2019, New Hampshire Medicaid covered 2,795 women in the pregnant woman category. 762, so that's 27%, lost Medicaid coverage 60 days out, as their incomes were too high, a little too high to qualify for the expansion for the granted advantage. We have a remedy to cover these women before us today. Our moms, their babies, and their families cannot wait. Let us take this opportunity to close this gap here, provide coverage, which provides access to health care and places New Hampshire families, their mothers, and our smallest, most welcomed new residents of our state at home and on a solid foundation for their life. I want to thank the committee for your time and ask for an ought-to-pass motion on Senate Bill 407. I am happy to answer any questions that you have. I do have other colleagues here, as well as the Department of Health and Human Services, who can assist me if I am unable to answer what you bring forward. Thank you.
Are there questions of Senator Prentice? Senator Whitley.
Thank you, Mr. Chair, and thank you, Senator Prentice, for bringing this bill. This is I think one of the most important bills of this session. You know, supporting our moms and babies is so critical. And so I'm curious in terms of, what our coverage is now for babies. Does this bill sort of match up coverage for moms that we already have for babies?
Essentially, it does.
Okay, thank you.
Thank you. Seeing no further questions.
Thank you for the question.
I think we're good.
Okay.
Unless there are other questions.
All right.
Thank you, Senator Prentice. All right. I would recognize Representative Murray. Good morning.
Good morning. Oops. Sorry. Coming in here. Let me. Good morning. Thank you, honorable colleagues of the the Senate Health and Human Services Committee. My name is Representative Megan Murray. For the record, I represent Hillsborough District 22 Amherst. And today I come before you in support of SB 407, seeking to improve the quality of care access for those postpartum and seeking to expand Medicaid service coverage from the current 60 days to 12 months of full coverage for postpartum care. While there are many reasons this expansion in coverage makes sense, I'd like to speak to a very specific area of postpartum care and medicine and provide the committee with a rationale as to why it's pragmatic and appropriate for the expansion in coverage to be expanded to 12 months. After pregnancy, there's often a time when a person needs care that extends beyond the initial 2 months, and that's often around mental health wellness. In many cases, postpartum issues around this area are not always fully identified and treated within the first few weeks post-delivery. Postpartum anxiety and depression and other related mental health care concerns are ones that take time, care, and treatment. Post-pregnancy, this expansion would give those who've just given birth the opportunity to have their mental health care needs more fully met, whether it is around lactation, mental health care, or other postpartum related needs. SB 407 offers an opportunity for those to receive the care that they need. I thank the committee for their time and hope that the committee passes SB 407, and I'll take any questions.
Thank you very much, Representative.
Thank you.
John Henry, would you like to testify? You haven't signed up, but I'm assuming. Go ahead, Henry. Thank you.
Thank you. For the record, Henry Lippman, State's Medicaid Director. I think this is an important piece of legislation to get into effect. The American Rescue Act provided that states who do this will get the federal match for the extended period of time. I think there are a lot of clinical people could speak to the observations that have been made with respect to the women's health, particularly in this period after they deliver a baby. I think the Fiscal Note, the department worked with the actuary, Milliman, to come up with an estimate on an annual basis between $200,000 and $1 million, depending on some clarifications that CMS made. Someone who's on Granted Advantage, for example, that the way it looks like CMS is going to be implementing this, the state wouldn't necessarily go back to sort of a 50% match on that individual who may have given birth while they were in Granted Advantage. So on the lower end is, if you will, the most favorable expectation, which seems to be the direction where CMS is going with it at this point. And I'll take any questions.
Senator Sherman.
Thank you, Director. And just for clarification, when you say the most favorable, you're talking about the 90-10?
Or something that is,
better
they're talking
than
about some
50-50.
sort of blended methodology that would be better than the 50-50.
Great, thanks.
Senator Woodley.
Thank you, Mr. Chair. Thank you, Director Lippman. I just want to thank you for your support of this population. I know you have worked really hard with your staff and your actuaries to get this to a place that's really workable. So I wanted to thank you for that. I wanted to, it's always difficult to sort of think through our savings, but I wanted to see if you had any comment about, like, what's our bang for our buck here?
Yeah, I think that's when you think about what hospitalization or extended for just one or two people can be, one specific analysis of that, but you can just well imagine we're covering today over 235,000 individuals. The childbearing age 14 to 44 is a substantial part of the population, and a few cases of bad outcomes for mother and babies. It's not just within Medicaid program, but it runs through the rest of it. Impacts education, impacts other services that end up having to be delivered, and so keeping someone healthy coming out of pregnancy so that they can raise the child and return to work, I think is well worth the investment many times over.
Any other questions? Senator Avard.
Thank you, Mr. Chair. Thank you, Mr. Lippman. With regards to the federal funds, is that perpetual? Is it ongoing as long as we have this program?
There's the American Rescue Plan provides for a 5-year look at this, and I think that that is sort of the end of that enhanced funding, but I think at that point, certainly we could reconsider if we're not seeing the return on it.
Yeah, one follow-up, if I may.
Mhm.
With regards to that, are there any strings attached from the feds?
Not, not specifically that would be any different than any other part of the program. I think basically having to provide eligibility on a consistent basis. I don't see that there are any other cost or.
So, I have a couple of questions. The fiscal note is between 200,000 and $1 million. The appropriation in the bill is for 200,000, and it's appropriated in this fiscal year. Do you think that that is a sufficient appropriation?
I think that 200,000 is likely, but until we get some experience, I think I tried to provide a range because I'm concerned until we have some experience that we ought to have some if you will, cushion there in terms of what the expectations are.
Okay. So, Henry, can you explain exactly how the 5-year extended FMAP, the federal assistance match, is going to work and what the funding levels are at? I think we've sort of gone around it, but I want to know exactly
Sure.
what it is.
So there are women that are in the group that is sort of the standard program where we receive a 50% match.
Yep.
What will happen with those individuals is that adding that extra 10 months of coverage, we don't expect that there be high cost services utilized in that period of time, and that the overall utilization of extending that, in terms of the types of services that are used to support that are sort of the preventative type services. If the 200,000 is sort of the general fund contribution. And then on the expansion population, one of the issues that when I was working on the fiscal note that wasn't fully known at that time was were people who were on granted advantage going to be then, once they were in that 10-month period, taken back to the 50% group. And what CMS has said is that they won't be, but they're not going to do it on a person-specific basis. They're going to develop some sort of methodology that's based on sort of experience, so that you don't have to file for each person and you don't have to do redeterminations on each person.
So any people that currently qualify for Medicaid expansion up to the 133% are not going to go back to the 50-50 match.
Correct. It will be on a I guess I'd say aggregate claiming basis. We'll get a credit for it. It may not be on a specific individual, but on an aggregate, when we file our claiming, we'll get an enhanced percentage that will be calculated on. They haven't completely done that for each state yet, so there's a little bit of uncertainty there, but it is certain that you're not going to be penalized by putting them back to the 50% category.
Okay. And what about the folks that are between 133% and the 196, where we provide benefits?
So if they're currently in the 50% match,
They're the ones that are in the 50%
yeah, right, and they'll stay there.
Okay. All right. Any other questions, Senator Whitley?
Thank you, Mr. Chair, and thank you, Henry. So just building off Senator Bradley's questioning, so the fiscal note will really be, is it correct that the fiscal note will really be for those slightly over income that won't be in the granted advantage, that will be at the 50%? Is that correct?
So we developed the 200,000 to 1
Yep.
million estimate represents looking at our current mix of individuals in the program, using that as a projection of what it would look like. The lower end, meaning the $1 million end, would be that we didn't get any extra match on the granted advantage individuals, and the 200,000 representing that we get sort of the perfect.
Yeah.
And I'm expecting it could be somewhere less than perfect, but the million is sort of an upper end expectation if we didn't get anything on extra on that.
Yeah, follow up?
Mhm.
And just to sort of allay any sort of concerns about, costs that'll just sort of run away, we do have a document from the UNH Institute of Health that really actually estimates the very, very small number of women that are in the program now that would be at this match. So we do have a pretty strong sense, don't we, of this number?
Yeah, it's based on experience, and I think our actuaries do a pretty good job in estimating our costs. I'm comfortable with. We put more into this because I knew it would be more of a concern anytime we're expanding eligibility. I know that the legislature takes extra interest, so we didn't just rely on department staff. We used our actuary to do it.
And I'm assuming when I'm looking again at the fiscal note, sorry to belabor this, but no money appropriated for 23, that's because the next budget will pick that up.
Right.
Okay, got it. And so we'll have the experience of FY 22 and hopefully no gap at the $200,000 appropriation.
I think that we should be comfortable with that, Senator.
Okay. I'm okay with that. You'll have to convince the finance committee to be okay with that.
Sure.
All right, thank you. Let's see, we do have a few more people to speak. Where's my list? Representing New Future. I'm sorry, NAMI. Had been New Futures. We love both organizations here in this committee, so you're in
I was going to say, you're trying to
good
get me to go back.
standing.
Chairman Bradley and members of the committee, thank you for the opportunity to testify today. My name is Holly Stevens, and I am the Director of Public Policy for NAMI New Hampshire. NAMI New Hampshire is a nonprofit, nonpartisan grassroots organization whose mission is to improve the lives of all people impacted by mental illness and suicide through support, education, and advocacy. On behalf of NAMI New Hampshire, I'm here in support of Senate Bill 407. You've heard some today about the maternal mortality rate, and just of note, country whose maternal mortality rate is currently rising. So I think that that's, it's something important to look at. And when a woman is on Medicaid and then loses it 60 days postpartum, it puts her in jeopardy of death. Many postpartum deaths happen between, hang on one second, about 1/3 of them happen between 1 week and 1 year postpartum. And so keeping these women covered for the full year would really ensure or help ensure that we could reduce the maternal mortality rate in New Hampshire. And also of note, you've heard a lot about postpartum depression in women, so I'm not going to talk about that today. However, the children of the women who experience postpartum depression are also affected. Research has demonstrated an association between postpartum depression and delayed cognitive and language development, disorganized or insecure attachment, higher rates of behavioral problems, and lower grades. There's also been a documented link between postpartum depression in moms and higher rates of depression in the children as they become teenagers. So not only would this assist in helping the moms, it would assist in helping their children as well. So I urge you to support this bill, and with that, I'll take any questions that the committee may have.
Great, thank you very much, Holly.
Thank you.
Seeing no questions. So now we'll get to Rebekah from New Futures. Sorry about that.
No problem.
I'm sure you like working with Holly.
Oh, I do.
Yeah, there you go.
And I apologize. I only have one copy of a report, and I'm
That's
just going to
fine.
make a.
We'll
I'm going to be
get copies.
great. I'm going to be brief. So, for the record, my name is Rebekah Voikovsky. I'm the Kids Count Policy Director at New Futures. New Futures is a nonprofit, nonpartisan advocacy organization that educates, advocates, and collaborates to improve the health and wellness of New Hampshire's residents. And my work focuses on children and families. We heard a lot today about how Senate Bill 407 will help to improve maternal and child health. I want to make one point that there is the New Hampshire Health and Human Services Legislative Oversight Committee that investigates cases of maternal mortality within our state. I have circulated a copy of a report from October 2020, which indicates that looking back on the maternal mortality cases that happened in 2018, all of those were related to overdose by medical issues exacerbated in pregnancy related to substance use or prior substance use. So when we heard Henry Lippman talking about some of these interventions would be low cost, likely it is the continued connection to medical providers. And that is also a recommendation in the report. So I just urge the committee to review the report, understand that we have moms that are dying from preventable deaths, and that this bill is a smart way to improve maternal and child health outcomes within our state. So we urge you to pass Senate Bill 407.
Terrific. Seeing no questions. Thank you very much.
Great, thank you.
Nancy Vaughan, Heart Association. Good morning.
Good morning, Chairman Bradley and members of the Health Committee here in the Senate. My name is Nancy Vaughan, Government Relations Director for the American Heart Association here in New Hampshire. And we are here in strong support of this bill as others before me came forward to also indicate this is a very important issue for New Hampshire and across the country. Heart disease and stroke are the leading causes of death in new mothers in the United States. So to ensure equitable health for all, we really must address maternal health at all stages of life. In New Hampshire, as you had just heard, it is substance use that has caused the deaths of many women in the last couple of years here. So it's just a very important issue for us to do in a preventive way. And obviously, what you've also heard is that 60 days is just not long enough. A lot of heart disease and stroke issues in women that might come from pre-existing conditions that they just weren't aware that they had and have become knowledgeable about as a result of their pregnancy. That the 12 months is very much so needed for the tracking and the controlling the risk factors that could lead to heart disease and stroke later in life, let alone deaths from cardiovascular disease in the postpartum period. And as you've also heard, there's ample research to show this as well, and we're happy to provide you with that information as well if need be. So again, I do have written testimony, which I'll turn in, so I'm not going to read the rest of my comments, but I really hope that you will decide to pass this bill. Thank you.
Seeing no questions. Thank you very much.
Thank you.
Last person signed up to speak, Courtney Tanner from Dartmouth. How are you? Good morning.
Good morning, Senator. Good morning, Courtney Tanner from Dartmouth Hitchcock, Director of Government Relations. Here to testify in support of the bill. Dartmouth Hitchcock Health is the home to NEPQUIN, which is the new Northern New England Perinatal Quality Improvement Network. And of course, we serve this population extensively. I've
submitted to Cameron testimony from Daisy Goodman, who's a certified nurse midwife. She also serves as our vice chair for research of our OBGYN department at Dartmouth Hitchcock Medical Center. Daisy, I won't read testimony, Senator Bradley, but Daisy is the lead of 2 HRSA projects that aim at improving care for pregnant and postpartum women, specifically looking to enhance the delivery of care for women who are struggling with substance use disorders. And we know that 90% of the pregnancies that Daisy and her team are seeing within her 2 projects are insured by Medicaid. This is double the rate of Medicaid insured in our state overall. We believe that this bill will allow women to re-enter the workforce faster in a quicker way. Women want to return to work. They're eager to return to work. And having a child, as many of you on the committee probably remember, is a pretty busy time during postpartum. And having one more to do on their to-do list, administrative to-do list, is just extremely challenging. So we believe that ensuring that extended Medicaid coverage for this population will allow this vulnerable population to return to work, specifically in most frontline work positions, home health care workers, et cetera. Finally, I just want to note, Rebekah did a great job talking about the maternity mortality review committee. Daisy sits on that committee, and you can find her testimony. She speaks to the need for coverage for this population, specifically for behavioral health services. I'm happy to take any questions, Senator Bradley.
Questions of Ms. Tanner? Seeing none. Thank you very much.
Thank you.
Is there anyone else? You're interfering with an exec session, Senator Perkins.
Why is that, Senator Bradley? Good morning, members of the committee. For the record, I'm Senator Rebekah Perkins Quokka, representing Senate District 21. I merely wanted to lend my voice in support of this bill. 60 days is most definitely not enough for postpartum coverage. In the case of both of my daughters, I was still in postpartum care well after that 60-day period. I have a 5-month-old girl now, and I'm still in postpartum care. So it's a major event for your body. It needs time to recover, and women need access to somebody monitoring them and making sure they can get back to work and get everything back in the right place. So just wanted to encourage you to pass this bill.
Thank you very much. I was only being facetious.
I kind of figured that out.
All right, seeing no one else, I'm going to recognize somebody, or I'm going to close the hearing. Thank you, Cam, and recognize Senator Sherman for a motion. All in favor? I'll recognize Senator Sherman for a motion. Moved, seconded. I'll speak to it. There may be some questions about the fiscal note when it gets to finance. I agree with those who believe that this absolutely is needed and will pay for itself in terms of better health outcomes. So with that, we deal with a policy. Oh, the last thing I would say, since we're running a $100 million surplus, this is clearly affordable right now. Yeah. So any further discussion? Seeing Whitley.
Yeah, thank you, Mr. Chair. I appreciate those comments, and I'm also in full support of this bill. To me, it's a no-brainer. We support moms and babies. It's good for moms and babies. It's good for our whole state. We get moms back to work. We keep them healthy. This is the foundation of our economy, and of course, the foundation of what makes New Hampshire so great. I do think it's pretty amazing. I want to thank all the advocates that have worked on this bill. I have worked with them professionally for many years, and they cross their T's and dot their I's. So this is a very well-crafted provision. And I also want to thank the department for really digging in on this bill and making it something that's really going to be workable and help all moms and babies in the state.
Okay, further discussion? Seeing none, all in favor, say aye.
Aye.
Opposed? Aye. So I'm going to recommend that we put this on the regular calendar I'm gonna, offer to take it out if everybody's all right with that. I'm
Great,
sure
thank
others will speak. Okay? Good. All right, move out of executive session, seconded by Senator Sherman. All in favor, say aye. Aye. Okay, so let's, apologies to, Senator Prentice, but, you know, we were taking care of your first bill. You're gonna make it so simple on the second bill, I hope?
I am going to do my best.
All right. We took care of your other bill the other day, too.
My greatest appreciation for all your work. Thank you. All right. Again, good morning. Good morning, Chair Bradley, members of the Senate HHS. I'm here before you today to introduce Senate Bill 408. This is legislation that would direct the Department of Health and Human Services to adjust the facility reimbursement fee for birthing centers to match the facility reimbursement fee that hospitals currently receive under Medicaid. This facility fee under Medicaid for these centers, the birthing centers right now, these are again freestanding licensed centers, it's $600. And from what I understand, it hasn't changed. And I can't track that back how far, but I'm sure that Director Lippman can. Today, there are 5 of these centers in New Hampshire, including Concord, Lebanon, Milford, Salem, and Swansea. And again, with no increase in the rates that they receive from Medicaid, there's the potential it could undermine their stability. That's why I come forward with this request today. Family choices for obstetric care for their children and for their childbirth experience matters. Licensed freestanding birthing centers offer that choice. Over the past 20 years, we have seen 10 hospital-based delivery units close in New Hampshire, most recently in 2020, Parkland Medical Center in Derry. Will this committee and the legislature consider this basic request to bring this parity under Medicaid for both, or for birthing centers to match that of the hospitals? We can't lose sight of the overall struggle that obstetrical care faces in the state. I see this as one small but important step in enhancing stability for all choices available to families. I ask this committee for an ought to pass motion, and I'm happy to answer any questions you might have. And if not, I'm sure there's someone in this room that can do it for you. That's it.
Questions, Senator Sherman?
Just a quick question. I think you said $600 for the outpatient centers. Do we
Facility
know?
reimbursement fee under Medicaid for those centers.
What would that go up to?
It would match what the hospitals are currently receiving.
I'm sorry. Did you say what the hospitals are currently receiving?
What the hospitals are currently, so this 600 would be raised to match what the hospitals currently receive.
I guess I'm just asking, what is that number? Do we know?
I'd have to ask Doc.
Okay.
I was actually looking at Senator Bradley's bill. That's about hospitals and reimbursement around.
Well, we can
Hopefully the department.
Yeah.
Yeah, the department should be able. I could only track down the $600.
Okay.
Okay.
Thanks.
Other questions of Senator Prentice? Seeing none. Okay, thank you.
Thank you.
Jim Monahan, New Hampshire Midwives Association.
Thank you, Senator Bradley and members of the committee. I'm Jim Monahan with DuPont Group. I'm here today on behalf of the New Hampshire Midwives Association. Mary Laure from Swansea, who's very active on this issue, had hoped to be here today but was not able to get over. So I'm going to hand in some written testimony from her. That testimony lays out the kind of the state of the midwives industry now, and then in answer to Senator Sherman's question, there's a chart associated and connected to that, which the department worked on us to prepare, which shows the differential. In Mary's letter, you'll see, I didn't want to read it to you, but you see that these are all estimates because on an annual basis, a birthing center costs are based upon the number of births, but there's no question that the estimated about $600, I think it's actually $582, has not changed since at least 2008 when Mary opened her birthing center in Swansea. In answer to your specific question, Senator Sherman, what will the rate go up to? That's not specified in the bill. What the bill does is it directs the Department of Health and Human Services to undertake a rulemaking to update the rate and make it compatible or comparable to the hospital facility rate. The reason we approach it that way is because we've had a very good working relationship with the Medicaid department and Henry on this, and we want to make sure it probably didn't make sense for it to be exactly the same because, as you know, hospitals' overhead is different than a birthing center, things like that. So we hope that this begins the process of advancing a more cost-based rate. In the testimony from Mary Laure, you'll see that she estimates the birthing center costs are closer to $3,000 per birth. And so you can appreciate we're not sending the right signals from the Medicaid reimbursement structure to encourage more folks to use the birthing centers or for the birthing centers to attract more Medicaid patients. So I know that Henry Lippman is going to testify and probably answer a lot of your specific questions. The bill has some great sponsors, some of them sitting in the room today. But I will do my best to answer any questions you might have. If I'm unable to, I'll ask somebody from the Midwives Association and get back to you when I can.
Senator Woodley.
Thank you, Mr. Chair. Thank you, Mr. Monahan, for your testimony. I don't know if this is a question for you or for Director Lippman, but the Medicaid program has a very well-known provision, Medicaid statute, that beneficiaries should have choice of provider, meaning just because you are low income, you shouldn't be forced to certain providers. So do you see that this improvement to the program as a way to improve choice of provider for moms who perhaps would want to choose a different type of birth experience?
Yes, I do. And I think, the concern here is that the birthing centers are financially very fragile right now. In addition to the low Medicaid rate, which I think could contribute to less choice if any of the 5 birthing centers do not continue to operate. There's also challenges associated with COVID. In some measure, the good news is more families seem to be, from what we understand, more families are choosing birthing centers so they're not at hospitals during this period. That has skyrocketed malpractice insurance. This whole other matter we're dealing with the insurance department on. So the other hope would be that with a more attractive reimbursement, that more birthing centers could open, which could address the very issue you're talking about, which is providing more choices for folks in the system.
So I have a couple of questions. I'm assuming from this chart that you've supplied that there are 53 Medicaid eligible children born at birthing centers statewide in some whatever period of time per year, I think.
Yeah, that was, yes.
2021, yeah. Okay.
Yeah, so we're not talking about big numbers, Senator, but for a birthing center, it can be a meaningful portion of their payer mix.
So it would appear if there was a differential of $2,400, it's about $127,000 cost, which I'll ask Henry the next question.
Yeah, and if this bill goes to fiscal, we'll certainly address those issues. But one of the interesting issues is there's probably not going to be more births than there would be otherwise. And so if those births took place in a birthing center as opposed to a hospital, and the birthing center costs were lower, then in fact it might not be a net cost to the state.
Could be. Okay.
That was one of the reasons we wanted to get comparability rather than specify a specific rate.
Senator Sherman.
Thank you, Mr. Chair. Hi, Jim. Just wondering if you can tell me off the top of your head, are these birthing centers in areas where there is where hospital services are not adequate? In other words,
I know.
If we lose the birthing centers, do we really lose access to OB care, obstetrical care in those areas, or is there some level of redundancy?
I'm not the best person to ask, Senator, but I know the department is here and they can probably answer that. Yeah. the testimony from Mary does list where the birthing, there's 5 of them right now. And they are in more densely populated parts of the state.
So I think, Senator Prentice, could you go through it again? It was Swansea, Concord.
Salem.
Swansea, Concord, Milford, Lebanon, Salem. Okay, thank you. Seeing no further questions of Mr. Monahan, Henry or Trish? I should have called you before. Sometimes, you know, with the masks, it's harder to see who everybody is all the time. Sorry about that.
Good morning. For the record, Patricia Tilley, Director of Public Health.
And for the record, Henry Lippman, Medicaid Director. I guess in this legislative session, we just, I guess, exec out, had to step out of the room, the postpartum. I think this bill, as well as I believe it's 401, which I believe you're the sponsor of, Senator, I think deal with, I think, the fragile situation I think New Hampshire is with respect to obstetrics maternity services for women. And I think that there's a number of things that need to be done, but I also think that there's, I think the last question you were asking, there's some geographic concerns that we have here, you know, particularly the North Country and the southwestern part of the state. I think one or more providers going out would create a desert, if you will, of where people would have to go longer. And I think, Trish, you can talk a little bit about what we're already seeing in some of our numbers with respect to births that are outside of where they should be.
Sure. Thank you so much. So to answer the exact question, we see that the birthing centers are in the high population areas, and that makes sense in part from a financial model, that is where folks are, and the reimbursement is not so great to really incent birthing centers anywhere we have low numbers of births. So while we have some a small sort of birthing center up in Lebanon, you really don't see anything north of Concord. We know in the state of New Hampshire right now, especially in our North Country, and as Henry said, also in that southwestern corner, we are having increasing numbers of out-of-hospital deliveries, or deliveries in places that were unintended is probably the more accurate way to say that. So that because we are seeing the closure of birth facilities specifically in the North Country, people are at longer drives. And so we're seeing births that occur occasionally on the side of the road, but more often in places like emergency departments, which is the absolute one of the places you certainly don't want to have a planned birth. I think that this bill is complementary to the other bills. As Henry noted, it provides additional resources and options for individuals, especially in that southern part of the state. It doesn't necessarily address the northern part of the state, other than we would all of a sudden have a different financial model where maybe there might be an opportunity for another birth center or a birth center to expand.
And I guess I would just add to that, there's a balancing act here, because the low number of births in the North Country in terms of spreading that out among more providers is also a concern, so that the hospital, the more complicated deliveries, have a place to go. I do think that it's been a while since, and I don't have the exact date since these rates have been addressed, but you know, the birthing centers are getting about 26% of what a normal newborn delivery is today, which would suggest, you know, since we're thinking we need to make some investment in hospital base, that's kind of a low figure. I also think, though, that in terms of the resources that the state may consider putting in play here, that we do have to take, I think, into account some of the geographic areas in terms of how we go about making this, because I don't think, while every area I think is struggling with obstetrics services just because of the costs and the population, that New Hampshire demographically is becoming one of the oldest states, that having some access in the North Country is really, I think, a critical thing, as well as that southwest corner. And I think hopefully we can work with you further along on, as you're considering these bills, on how to maybe calibrate this a little bit to, take into account the various geographies here.
Any other questions? So I just have one. According to the testimony of Senator Prentice, the way this bill is structured, you would have to adopt by rule any changes that would be made. So wouldn't that allow you to take into consideration by rule some of the geographic problems that you've just highlighted?
I think it would, but I also think, Senator, that potentially, I've had conversations with Taylor Coswell. I don't think Medicaid alone can solve the issues that we have. We've had conversations with the Department of Insurance as well. I think it's really going to take I think several different sources to secure birthing access in the state.
Okay. Thank you very much. I don't think we have anybody else signed up to speak on this. I know a little bit about birthing centers because my daughter was born in the Concord Birthing Center and was a really good experience. So I'd entertain a motion after I close the hearing. All right. Is there a motion? All in favor? Aye.
Aye.
All right. Now is there a motion?
I move ought to pass on 408.
Seconded by Senator Sherman. Any further discussion than we've already had? Seeing none, all in favor say aye.
Aye.
Opposed? Is there a subsequent motion? Moved by Senator Sherman for consent. Senator Sherman, you want to take this one? Sure. Okey-doke.
We have to vote on that motion.
Oh. Everybody in favor of consent? Aye.
Aye.
Any opposed? Okay. Thank you very much. All in favor of coming out of exec? Aye. All right, let's open the hearing on our next bill.
This is Senator Prentice Day.
You're doing so well, Senator Prentice.
Yeah,
You're
she's
now
2
3
for 2 so
three.
far.
No. We gave her one yesterday too. Yeah.
Okay. Well, once again, good morning. So I am here to introduce Senate Bill 419, and this, again, good morning, members of the Health and Human Services Committee. I'm here before you today to introduce Senate Bill 419. This is legislation that would codify New Hampshire's 13 regional public health networks. For clarification, this bill does not replace or supersede the role of a town or a city health officer. In fact, this bill clarifies what networks are, some of the basic roles, and how they share governance regionally. This bill lays the foundation for a formal public health infrastructure in New Hampshire. In the late 1990s, the Turning Point Foundation funded the establishment of regional public health networks in other states as well as here in New Hampshire. They saw this as a regional approach to delivery of public health services, bringing together communities that traditionally share services. For example, mutual aid for fire and emergency medical services are geographically aligned, as well as work with the same hospital and healthcare community catchment areas. As you already know, not all New Hampshire cities and towns can afford their own public health department. Manchester and Nashua have their own public health departments, and Portsmouth has a part-time one, but outside of that, this is a shared responsibility amongst these networks. The rest of the state does rely on this regional approach. In the mid-2000s, federal dollars, this was after not only 9/11, but this is after Hurricane Katrina, we saw federal dollars come in to the state to build out even more capacity at these networks under emergency public health preparedness. And this is obviously notable now. It's placed in these networks, but we're seeing the work that they're doing because of COVID has really raised the profile and the understanding that we need more of a public health infrastructure in the state and what these networks are already doing, including testing, vaccinating and boosting. I'm proud to say that I participated in the booster blitz as a vaccinator. I know Senator Sherman did, and the public health network in my area was actually worked with the state to set up that large site. So they are out there and doing the job. The state's health improvement plan also cites regional approaches and infrastructure for public health as priorities. In Appendix C, specifically, what forces of change are impacting New Hampshire includes a focus on addressing limited public health capacity and the ability to respond to emerging issues. This includes the regional public health networks. Now more than ever, I believe that we understand the importance of public health and the work that these networks perform. I believe a time has come to lay this foundation, formally recognize their excellent work through codifying the system. However, I recognize that after multiple discussions that not all stakeholders are on the same page as to how to go about this. They support the basic concept, but it is the nuts and bolts of the legislation in terms of how this would operate and impact them daily that have raised some concern that I'm still in discussions with different stakeholders. So I'd like to ask that the committee consider the legislation, but give me some additional time to continue to conduct these conversations and see if I can get everybody on the same page. So that is my request. I am happy to answer any questions that you might have.
So are there questions of Senator Prentice? Senator Whitley.
Thank you, Mr. Chair. Thank you for taking my question. So in New Hampshire, we have a lot of different regional networks. We have the community mental health centers. We have the area agencies. We have the IDNs. And so I'm wondering sort of how our existing public health infrastructure, these networks, how does that line up with the other regional systems in New Hampshire?
Some of it does, and some of it does not. Now, some of the public health networks are housed, their offices are housed with some of these other regional entities. I think you're talking about area health education centers as, being one of them. I took part in a meeting back when I worked at the Department of Safety when we were trying to sort all this out, where it was held at Health and Human Services, and we took all the different maps, hospital service areas, public health networks, EMS regions, all the different ones that existed, and we put them in a, remember the old transparents, what are they, the overhead projectors, and we tried to form more cohesive networks that looked alike. So it's common that they do, but some do cross into other areas, which is just, it was not an easy task to accomplish. I think we still struggle with that.
Senator Sherman.
Would you believe that, and Director Tilley knows this, that Shawship right now, the advisory council has formed a subcommittee to map our healthcare networks and all the connections and all the services so that we do understand these networks better. I notice here that it is enabling, right? In line 13, it says a public health network may establish a public health council. Are you hoping that this will be enacted across the state, that all will want to do this, or is there a reason why a public health network would not want to do this?
So I'm going to answer that in two ways. One of the, you look back, you submit your legislation, you look at it again, and then you're getting ready for a hearing. And as I was looking, and I've also been talking a lot with stakeholders, if you didn't know that there were already public health networks in this state, you would look at this and think this is brand new. So I believe that there's some adjustment in that language, because this is really about codifying and formally laying the foundation for a public health infrastructure based on what already exists. Now, to get to the council part of this, all of these networks have some type of oversight or advisory council. So if you go on you could either reach this through the public health's website. There's a number of different ways to look at it. If you have a public health network, you may have an advisory council. And then I described what I thought the governance or the representation should be and tried to engage the municipalities in that, which is not always the case. It's not that it isn't available to them, but over time, some of the municipal interests who are participating in these networks have kind of moved on to other projects, and we'd like to bring them back into the fold. And actually, during COVID, many of them have come back into the fold. So it looks as if we're newly establishing this. I have to tweak that language to recognize that this is already existing, but we're just like the community mental health centers, we're going to recognize it. I'm proposing we recognize this formally, lay the foundation for the public health infrastructure in the state because it doesn't exist in that way. And if they want to have an advisory council, they should. I feel like I'm just warming up and this is number 3 and I'm going to be done.
So I have a couple of questions. I think, if I understood you correctly, you asked us to hold the bill, not exec it.
Correct.
And you are going to work with the department on some language changes. Is that correct?
Correct. I've worked with the department and I want to work with them on the language changes. It's some of the public health network folks who support this who are concerned about the operationalizing of it, Senator Bradley. So that may bring about language changes as well.
Okay, no one else has signed up to speak on this, and I'm just, other than the department, for information purposes. I just see the opportunity for, some turf issues here amongst the existing public health networks. So just make sure that when you get back to us that you've touched base with all of the necessary people, since they haven't signed up to speak here.
Mm-hmm.
I'm assuming that means they're in favor because people are louder when no is the response as opposed to yes, but I'm a little bit surprised by that.
Senator Bradley, respectfully, I'm concerned about turf issues as well, and that's part of the reason that I want to draw back and make sure we address that. I've worked with the New Hampshire Public Health Association and entered into a discussion with them about this, which in concept, the support is there. This is public health infrastructure is a priority. It's how it would actually work. And that's what I've heard from at least 3 of the public health network individuals that I've spoken to. And it really led me to the place to say, slow this bus down, see what you can do to fix this. I might come back and ask for this to be studied if we can't get to that place, because I do think that this is our future.
Okay, very good. Thank you very much, Senator.
You are welcome.
You're now not going to be 4 for 4.
That's
Yeah, well, every day is a different game. So, yeah. All right.
I feel like I just got it, but
You're
that's
doing pretty well.
That's where it's at.
Okay, I would now recognize Ian Watt of the Department of Health and Human Services and Stephanie Locke. Good morning, folks.
Good morning. Can you all hear me? Good morning, Chairman Bradley and members of the committee. Thank you for having us here. My name is Ian Watt. I'm the Deputy Director for the Division of Public Health Services. I've been in my position since November of 2021. So you may not have seen me before, but I appreciate the opportunity to be here today to discuss this bill. I'm joined by my colleague, Stephanie Locke. Stephanie is our Bureau Chief for Emergency Preparedness, Response, and Recovery in the Division of Public Health Services, our most newly formed bureau, and has been a tremendous credit to our team over the course of the pandemic since she's joined. We're here today to share potential or information related to the proposed legislation, Senate Bill 419, relative to public health networks. As you know, the bill has 3 main components. One calls for our commissioner and DHHS to establish the regional public health networks. It also adds criteria for the creation of regional public health councils to advise the networks and composition for these councils based on the municipalities participating. And then finally, it establishes responsibilities of the public health networks to plan for and prevent public health emergencies. So I want to just give a little context on the public health networks. The networks have really been the core of our public health infrastructure locally in the state now for almost 20 years. They began in the early 2000s and began receiving formal funding from the state and through the state as early as 2006. There are 13 public health networks representing diverse areas They were formed with the intent of common social and economic backgrounds so that they would be a coherent structure for local authorities to disseminate health information and health services. They are funded as a partnership between our division in public health, as well as the Bureau of Drug and Alcohol Services in the Division of Behavioral Health. They are diverse in both their makeup and their management. They include local health departments, healthcare providers, and social service agencies. And they really are our key conduit for messaging and health services to a diversity of local partners: schools, fire, police, emergency services, behavioral health partners, and leaders in the business, government, and faith communities. And really the asset that they bring to the state beyond that local presence is being a trusted partner in a way that we, as Senator Prentice noted, by not having local health departments, having a local trusted partner in the dissemination of public health resources has been invaluable to us throughout the COVID-19 pandemic and otherwise. Within public health, the core functions of the public health networks are an emergency preparedness, routine childhood vaccination, and adult influenza vaccination. We have more recently and in recent years had non-core programs related to lead prevention services, as well as environmental health protection. The core functions in the Bureau of Drug and Alcohol Services focus on awareness to and access to substance misuse prevention, treatment, and recovery services, as well as promotion of evidence-informed policies to promote healthy communities. So I want to take a minute to speak about the contributions that the public health networks have made to our COVID-19 response. Really, since March of 2020, the public health networks have been at the core of our local activation of services and resources for communities, both general population as well as hard to access populations such as homebound individuals, low-income communities, and school children. We have worked with the public health networks to deliver PPE to relevant parties, to deliver testing kits and testing services, as well as to activate vaccination clinics, including the recent Booster Blitz and Booster Blitz 2.0. So we've been very grateful, and really the public health networks can't be credited enough for their tireless efforts. They have been asked and stretched beyond anyone's reasonable expectation, as many of us have over the course of the past 2 years, and really have allowed us to serve the people of New Hampshire in a way we otherwise would not have been able to. Looking forward and looking at this bill and beyond, we have had a tremendous opportunity to assess our local health need and assess the confluence of services, in public health and across mental and behavioral health in ways we have not previously as a result of the pandemic. We have continued to assess internally the best way to deliver these services going forward, with the public health networks intent on being a core of that service delivery model. One ongoing challenge that we face and the public health networks face is continued sustained and flexible funding. We have found throughout the pandemic that while we have been well funded by our federal partners, the funding sources do not always allow for flexibility to local needs. And looking at the instance of a recurring and sustained funding source going forward would be a really critical asset to ensuring that these are well-sourced and also flexible to the needs of local communities, which we have seen can vary greatly within a community and within a network. So I wanted to thank you again for the opportunity to appear today. That concludes my testimony, and Stephanie and I would be happy to welcome any questions you may have of us.
Senator Whitley.
Thank you, Madam Chair, and thank you both for coming here today and all your incredible work. We're very appreciative of your work during this incredibly difficult time, so thank you. So you had mentioned sort of the challenge here, I think going forward, is this the availability of flexible and sustained funding. So I'm curious whether in other states, whether that flexibility, does that come from state funding? Is there other opportunities for federal funding? How does that work in other states, if you're aware?
So I'll speak in general terms because I don't have, it certainly depends on which state you choose and how they choose to model. Every state and territory has access, with minimal exception, to the same federal funding sources and has throughout the pandemic. At a local level, local decisions are dictated by local governments. Many states, and New Hampshire, I won't say the least, but in one of the lower percentiles, we have a decentralized public health system. We have the fewest local health networks, or local health departments, excuse me. The local health departments tend to receive direct funding from their states, or potentially other local tax or other contributions. We don't have that model here in New Hampshire. We, have leveraged, I think, our federal resources to the maximum. We frequently get requests for more at the local level, and between our state level programs and our local programs through the networks, we certainly work to achieve the most equity across programs and across the community that we can, but have found throughout that the networks have appealed for more, and we have given all we can within the context of what we have.
Okay. Thank you very much. I don't have anybody else signed up to speak on this bill. Senator Prentice, you've made it clear what you're going to do, so I will close the hearing on Senate Bill 419. And we'll open the hearing on Senate Bill 444.
Thank you, Mr. Chair. Good morning, members of the committee. For the record, my name is Becky Whitley, and I'm honored to serve New Hampshire Senate District 15, which include the wonderful communities of Concord, Pennacook, Henniker, Hopkinton, and Warner. So I'm honored today to bring forth Senate Bill 444. This is what we're calling the ACEs Treatment and Prevention Act. This bill builds on the many years of bipartisan work to improve New Hampshire's children's mental health system, something that I personally have spent my career working to improve. So as this committee well knows, I care deeply about New Hampshire children, and I want to make sure that every child has the same opportunity as my child to grow into a healthy adult, regardless of their background. In 2019, the legislature passed historic reforms to the children's mental health system in Senate Bill 14. The bill before you today takes that work upstream and shifts our focus to prevention and early childhood. We want to solve the question of how do you prevent crises before they happen for New Hampshire children and families? How do we identify vulnerable children and support them before they end up in our emergency rooms? Unfortunately, rates of childhood mental health concerns and suicide rose steadily between 2010 and 2020. And by 2018, suicide was the second leading cause of death for youth ages 10 to 24. That takes my breath away. Over the course of the COVID-19 pandemic, we have witnessed soaring rates of mental health challenges among children, adolescents, and their families, exacerbating the situation that existed prior to the pandemic. Children and families across our state have experienced enormous adversity and disruption. In October 2021, the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association declared a national state of emergency in children's mental health and called on policymakers to advance strategies to meet these challenges through innovation and action, using approaches to improve the access to and quality of care across the continuum of mental health promotion, prevention, and treatment. Today, we have the opportunity to heed that call by supporting SB 444. This bill looks at young children and identifies solutions to better support them and prevent crises down the road. This is critical because the social and emotional capacities that children develop in early childhood serve as the foundation for experiencing and managing emotions, creating stable relationships with peers and adults, exploring and learning in their environments, and acquiring developmentally appropriate competencies. But unfortunately, research shows that traumatic experiences and stress during the first year of life, called adverse childhood experiences, or ACEs, can impact a child's brain development, their educational achievements, and future economic productivity. Young children birth to age 8 are the most vulnerable members of our society, both in terms of risk for maltreatment and with regard to biological sensitivity to adverse exposure. But the good news is that high-quality, evidence-based early intervention irrefutably has been shown to be more cost-effective and have greater societal impact than waiting to intervene downstream. Early intervention impacts have broad reach and it can improve children's cognitive, social, emotional, behavioral, and physical health and well-being, and are more likely to have lifelong benefits. So in addition to building on the work in Senate Bill 14, this bill supports the prevention and early intervention goals identified in New Hampshire's 10-year mental health plan of 2019, which many of these committee members have worked so hard on, the Council for Thriving Children's 2020 strategic plan for early childhood, and the department's infant and early childhood mental health plan. So I will do some broad brush, and then I will take the committee through the actual bill. So the bill in general builds the workforce capacity to alleviate the widespread shortage of qualified mental health providers across the state for young children and their caregivers. This has been identified time and time again as a huge gap in New Hampshire. We have to build the workforce capacity to serve these children and families. It also pilots a new level of home and community-based care for young children, something that this legislature implemented in 2017. This takes that program for young children. And it also expands evidence-based mental health interventions for young children, particularly those for known exposures to ACEs and who are considered at risk for behavioral health concerns in childhood. And it also supports New Hampshire's primary prevention infrastructure. So going to the bill, I wanted to just sort of take the committee through the various portions of the bill because it is a long bill. But it does all work together. So the first and second sections sort of speak to themselves. I think it's important for the committee to sort of read through the purpose statement about why this is so necessary. Going to section 3 on page 2, this is the pilot program that I mentioned. So in 2017, the legislature appropriated and approved a program for the state to get a 1915I Medicaid waiver for children at risk of acute hospitalization, psychiatric hospitalization, and at risk of out-of-home placement. So this pilot program extends that program to young children. So the 1915I only applies to children 6 and above. So this will pilot the program for younger children using the existing care management entities that already provide those services. And there's an appropriation in there. And I just want to note that, so we have a new children's behavioral health director, Rebekah Ross. She's still getting up to speed, but she did let me know that DHHS has secured some ARPA funds for this purpose, but not entirely, not in its entirety. So it may be that on page 3, that section 3, but that appropriation might need to be adjusted in line with what the department has already received. So that can be done in finance, I think, very easily once we hear from the department about what is actually needed to do that. Section 4, section 4, 5, and 6 really just looks at the existing system of care statute. So 135F, again, was a bipartisan bill passed by this statute, or passed by this legislature. It's the Children's Mental Health Statute, which we built upon in Senate Bill 14. These few sections takes a look at what's necessary to build into the system of care for young children and making the system more trauma responsive. Going on to section 7, this is something that's building on the infant mental health plan. So the department has worked with national organizations. It's an organization called 0 to 3, and they worked with stakeholders to develop an infant and mental health plan. Part of that plan is built into this section. So that sort of speaks to itself. And section 8, so we're on page 4, section 8. This is an appropriation for child-parent psychotherapy to build the workforce. So again, we have seen from study after study, report after report, that one of the biggest challenges is building our workforce capacity to provide important services. The state has invested a significant amount in both state dollars and philanthropic dollars to build child-parent psychotherapy, which is a very effective, evidence-based, but expensive intervention to serve children and families. So this appropriation is for a 5-year plan that has been written already to build the workforce capacity. This is something that's already in place. We just need to get this over the finish line to have the appropriate amount of folks to provide this important care. Section 9 is an additional appropriation for training, a workforce training model, the ECHO model, that was requested by the department. And then lastly, Section 10 is an appropriation for the Family Resource Center. So pulling this all together, you look at this bill as a prevention bill and a treatment bill. This section looks at our existing infrastructure for primary prevention. And when I say primary prevention, I'm thinking about those supports for families to prevent child abuse and neglect. The Family Resource Centers around the state do this incredibly important work. They need this sustainability funding once federal funding runs out at the end of the year. And there are certainly other folks behind me that can speak more about that. We do have some information for the committee about child-parent psychotherapy. There's a letter coming about that. We do have information about the Family Resource Center. So I am not the expert about that, but I'm happy to take any questions about the bill. Thank you. Oh, and I'm sorry, the other thing that I wanted to mention is that I apologize for the last minute nature of this, but we do have an amendment that you should have in front of you. It's Amendment 0190. The first part of the amendment just makes some minor just language changes. They're not big changes. It's just sort of drafting things that we needed to clean up. But it does insert one more section. So if you look on page 2 on the amendment, we look at the existing resource center for children's mental health and make sure that it has the appropriate capacities for early childhood. So that was inadvertently left out of the bill, but certainly an important part. Certainly an important part of the structure to make sure that this existing resource center. So unfortunately, too, we will likely need to figure out what the necessary appropriation is for expanding that existing contract for that resource center using ARPA dollars. So you'll see that every appropriation in the bill looks to ARPA. And these are very important and appropriate uses of ARPA because you're building capacity. This is not like sort of long-term funding. This is dollars that are necessary to build the system, and then will pay for itself going forward. So I wanted to note that about the funding mechanism. So again, happy to take any questions.
Senator Gray.
Just to point out, in your amendment, line 1 says replacing subparagraphs Roman 1C through D. It lists C through E, and if you're going to, it looks like E is the same both in the bill and the replacement, so that appears to be a drafting error that would need to be corrected at some
Yeah, we
point.
just got this from LOS this morning. Thank you for pointing that out.
And I haven't had time to go through the rest of it
Sure.
in detail. But.
Sure.
And I haven't got the amendment, and I'm not sure Senator Avard has the amendment. Okay, thank you. Other questions? All right, I have a couple. So currently, this adverse childhood event is funded to age 6. Is that what I understood? And you're expanding it up to age 8?
No. So there is a bucket of Medicaid services that the state receives funding for under a 1915I waiver, and that was approved in 2017. That's for families with children 6 and above. And so the pilot program is to include younger children.
Oh, okay.
Yes.
All right, I misunderstood that. Okay. And second question. So the way the fiscal note is written, it comes out of ARPA dollars. is that in the state's discretionary dollars, or is it out of a specific dedicated ARPA fund that's outside of the state's discretionary dollars?
Discretionary dollars.
It's in the 900 and whatever it is, 960. Okay. Okay. Are there other questions? Seeing none. Okay, we have several people that have signed up in support of the bill, not wishing to speak, but those that I have wishing to speak are Rebekah from New Futures again. Good morning.
Have testimony for myself as well as former Representative Joelle Martin from Milford Thrives, and then Cassie Yackley, who's the director of the Center for Trauma Responsive Practice Change. She is the CPP expert within the state. Both of the individuals could not be here today, but I offered to submit their testimony in lieu of their presence. So I'll be short and sweet. For the record, my name is Rebekah Voikovsky. I'm the Kids Count Policy Director at New Futures. New Futures is a nonprofit, nonpartisan advocacy organization that advocates, educates, and collaborates to improve the health and wellness of New Hampshire's families. My work centers on improving the health and wellness of children and families. New Futures stands in strong support of Senate Bill 444 because it is imperative that the state invest in primary prevention programs which are critical to the prevention and mitigation of childhood trauma and provide multi-generational supports which enable families to thrive. We all understand that the COVID-19 pandemic and the ongoing mental health, substance use, misuse, and child protection crisis have negatively impacted New Hampshire's families and have placed increasing pressure on all child-serving children's behavioral health and child protection services. New Futures supports the entirety of the bill, but in particular supports the appropriation to make investments in child-parent psychotherapy and family resource centers. I am not a CPP expert, but CPP is an evidence-based therapy for caregivers and young children birth to age 8 who have experienced traumatic events or other traumatic stressors which can disrupt normative development and who are experiencing mental health, attachment, or behavioral problems. CPP has emerged as one of the most frequently employed models in the state, largely due to CPP's effectiveness with traumatized young children and their caregivers. You might be familiar that many towns have ACERT programs that refer families that and children who have experienced trauma. The demand for CPP is astronomical, and we can't meet the needs as the state is structured right now. This investment will increase the availability of this critical services for families, and it's an important intervention. New Futures also appreciates the inclusion of in Senate Bill 444 with the appropriation for family resource centers. The bill proposes an investment for infrastructure supports for family resource centers. Family resource centers sit at the heart of our communities that they serve. Programs and services provided by FRCs have been proven to mitigate the impacts of trauma. Despite this importance to both child well-being and the provision of state services, there's no comprehensive funding. The state has made an investment since 2019, I believe, on a facilitating organization model. That investment is $325,000 a year. It has been critical and very effective to be able to leverage additional federal funding. So the increase of the appropriation contemplated in Senate Bill 444 would enable greater infrastructure growth to meet the needs of families within the state. I should note that I am also the chair of the Wellness and Primary Prevention Council, which is a statutorily created committee which oversees the development of a statewide network of family resource centers. That body has been in place since 1999. So the concept of building a cohesive statewide system of family resource centers is not a new idea. We have just made really great headway over the past couple of years with this acknowledgement of how early childhood trauma affects kids and families and how we can help in a multi-generational approach. I'm happy to answer any questions, but we urge the committee to vote this bill ought to pass.
Thank you very much. Questions, Senator Whitley?
Yeah, thank you, Mr. Chair, and thank you, Rebekah, for your testimony. This is the other Rebekah W. and the reason why I'm Becky going forward. So Will you, so I had mentioned briefly, but I don't remember the details honestly about how much or how the preschool development grant money was used for family resource centers and why, this
Sure.
kind of thing is necessary.
Right. So the preschool development grant included a provision for infrastructure supports for family resource centers within the first year. But given the change in nature of needs within the state, that allocation of federal funds was not included in the second year and will run out. So what family resource centers were able to do with that funding was to increase infrastructure supports to serve more families. So the amount that's contemplated in here is the amount that was originally included in the preschool development grant.
Thank
Thank
you
you
very
very
much. I would now recognize Holly Stevens from NAMI.
Good morning, Chairman Bradley and members of the committee. My name is Holly Stevens, and I am the Director of Public Policy at NAMI, New Hampshire, the National Alliance on Mental Illness. NAMI, New Hampshire is a nonprofit, nonpartisan grassroots organization whose mission is to improve the lives of all people impacted by mental illness and suicide through support, education, and advocacy. On behalf of NAMI, New Hampshire, I'm here today to speak in support of Senate Bill 444. I will be very brief for you. So just a couple of things. We know that high quality evidence-based early intervention has been shown to be very effective and also cost effective. If you can get in and get treatment in earlier, the outcomes are much better for the kiddos later in life. So with that, just wanted to reiterate with what Rebekah just mentioned, that there are not enough CPP certified therapists within the state to cover the need. So having the extra funding would go a long way to really getting these families and the kids the treatment that they need. Senate Bill 444 would go a long way to ensure New Hampshire's children who have experienced trauma or otherwise have severe emotional disturbances get the treatment they need, and it would further the state's goal of supporting prevention and intervention that's outlined within the state's 10-year mental health plan that came out in 2018. So with that, I will end my testimony. And
Okay, thank you. Seeing no questions.
thank you.
Last person that signed up to speak, and I'm going to have some questions of you, John, is the child advocate, Miss O'Neill. No, I'm sorry. Go ahead, Miss O'Neill, and then John.
Good morning. Good morning, Chairman Bradley, Vice Chair Gray, esteemed members of the committee. For the record, my name is Moira O'Neill. I'm the Child Advocate for the state of New Hampshire. As you know, the Office of the Child Advocate is an independent agency mandated to provide oversight of state and state-arranged services for children and to promote their best interests. I appreciate the opportunity to speak this morning in support of Senate Bill 444FN relative to childhood adverse experiences, treatment, and prevention. We support this bill with one small recommended adjustment, and now seeing the proposed amendment, we also support the amendment. This bill expands the system of care to ensure a robust, comprehensive, and all-inclusive service array for all children of all ages in New Hampshire. Many of you I know have worked really hard over the past 4 years to create a responsive system of children's behavioral health. This bill represents a missing foundational stone to that system. So with the Child Advocate's singular access to information, we can give life to these kinds of policy proposals. So I'd like to give you some life for Senate Bill 444 by sharing the experience of one of the first boys I met in this role as the Child Advocate. At the time he was 16 years old, he was placed at a residential program. He was asking for a family. As is the case with most teenagers in state custody, he was not having a lot of luck being matched for an adoptive family. He was also not doing well in the residential program. He tried but could not keep a job off campus because of unsafe behaviors. He sometimes took property that was not his. He was not always truthful. He was not doing well in school, and he was stuck. He had biological relatives with occasional contact, but none who felt they could take care of him. When I sat down to review his lengthy case record and understand what brought him into the care of DCYF, the Division for Children, Youth, and Families, I recognized immediately a whole cascade of missed opportunities. The boy was known to DCYF almost from birth. One of the earliest referrals to DCYF about him came from a child care provider. The provider reported that the child's mother routinely picked him up late, never brought enough formula, left dirty bottles with which to feed the 7-month-old boy, and did not have diapers. More referrals to DCYF followed for failure to protect the child, medical neglect, and other chronic neglectful behavior. Many of the early allegations of neglect or abuse were unfounded. His mother was trying. Some unfounded allegations were assessed as considerable risk. By the time he was 7 years old, he was in state care and has been since. Today at 20, he's receiving extended services. He's homeless and he's struggling with substance use. He will likely rely upon the state for many years to come. Since then, I've reviewed records of many more young people with the same early adverse experiences and the same missed opportunities. That boy represents the opportunity and value of the investment in early intervention that Senate Bill 444 pilot offers, the ACES pilot offers. So as you've heard this morning, adverse childhood experiences, exposure to abuse, neglect, other traumas have been found to interrupt normal child development. In particular, the child's brain development. Children's brain, we can see now from fascinating magnetic resonance studies and other research, develop in phases. Each section of the brain and all its neuronal connections are associated with certain thresholds or windows for learning and skills development. This includes regulating emotions, recognizing social cues, cognitive function and intellect, language skills, and more. If a child experiences an adverse event, we see physical and chemical change in the brain. If it happens during one of those windows of opportunity, the associated skill or ability may never be achieved. So this is where you can predict poor school performance, disrupting behavior, delinquency, poor employability, and chronic illnesses, including substance use, obesity, diabetes, and other disabling or complicating conditions that can last a lifetime. So the good news is that because children's brains remain so malleable throughout childhood and adolescence, they can experience healing and resiliency with the right intervention. So home visiting programs providing parenting support and child development education to new parents are probably the most evidence-based programs with successful outcomes for children in the field. Senate Bill 444 would extend availabilities of those programs. Child and parent psychotherapy, as you heard this morning, another evidence-based model of care with impressive success that only treats a child exposed to trauma, that not only treats the child exposed to trauma, it also treats the parent's unresolved trauma and adverse experiences, building up the parent's resilience to better nurture and heal their child. So Senate Bill 444 not only expands availability of this remarkable model of care, it fortifies the workforce to do it. And in the training and the need to build that workforce, I want to also point out that this is an area that doesn't require bringing new providers into the state, which has been such a struggle. There are providers already here who can be trained to provide CPP. So on that case, it's not as much of a heavy lift. So the ACEs prevention and treatment pilot program for children birth to 8 years old proposed in this bill targets those critical growth thresholds I'm describing and sets children on a path for healthy development. It's a family strength that the boy I described and his mother had access to childcare. That was really something, that he was going to a childcare center. But the infrastructure of support appeared to stop there. So had that little family been embraced by a local family resource center, supported by a CPP therapist in those early years when childcare was calling on concerns about insufficient food and attention, think about what his outcomes might have been. The cost of the pilot and the investment in training providers in CPP or innovative case learning programs like ECHO likely represents considerable cost savings for the state compared to what has been spent in over 10 years of expensive and ineffective residential programs for one boy and continued to spend in his extended services. So the Senate bill contemplates a careful rounding out of the system of care, and it's addressing the earliest, most important years of a child's path to success. It includes careful consideration for building the workforce capacity. It strengthens local family resource centers and pilots a holistic approach to the youngest, most at-risk children. The pilot's going to demonstrate the value of this approach and readiness for the next budget and state investment improvement supports for strengthening New Hampshire families. I'd like to also point out that in the proposed amendment that would establish a resource center for children's behavioral health, this is a really important addition, not only to support new providers and new services for very young children, but it would support all of the services that children are accessing in behavioral health. And I would point out that the boy that I'm describing, in the many years that he got late treatment and late attention in the residential programs, those programs were not evidence-based programs. He was not receiving services that would have helped him heal and become resilient, and therefore were not effective, which explains another reason why he's still in the system today at age 20. So the only adjustment that we would request in the bill is on page 4, lines 4 to 7, section 4A, in which the department is mandated to provide a detailed report on the pilot. We ask that the department also report to the Office of the Child Advocate so that we can assess the outcome and cost benefit of the pilot and provide guidance on further investment and program adjustment. Legislative committees, who are often the point of reports being submitted, often change. The Office of the Child Advocate is therefore the steady source of oversight and would be a good resource to the committees of cognizance. So for these reasons, I urge you to pass Senate Bill 44 relative to childhood adverse experience treatment and prevention with these recommended adjustments. And I thank you for your time, and I'm happy to take questions if you have any.
Senator Mark.
Thank you, Mr. Chair. So, thank you for your testimony. And with regards to this young individual, stating that he was in the system at the very young age, the state failed him, right, through DCYF, because he just was constantly going before them. There were constant things. I'm having a rough time with that because now we're saying, well, we want more of the state intervention. And the state seems to be falling through. Why wasn't he picked up under the existing programs at a 6 years old or at 7 years old? Mm-hmm. What happened there?
Sure, thank you very much for that question, the opportunity to clarify. So what Senate Bill 444 does is it creates programs early on that don't exist right now or just barely exist. And if you look at how a child's brain develops, if we had intervened with him at 7 months, at 1 year, at 2 years, 3 years, 6 years, then we might have avoided his subsequent involvement in the system. So once you get past these certain thresholds of learning, there may be behaviors or incapacities or disabilities that are kind of stuck there. And it would take a lot of real expertise in order to help him learn, train to come around to that. So number one, the intervention from the state started late. So I don't know if I would call that a failure of the state because the state wasn't there to help him at that time. There were no programs then. There also were no voluntary services programs at that time, which have since been instituted. So maybe would make a difference as well. But then what we understand about the traumatized child and adverse experiences is still relatively new information. And the state also only recently began contracting with residential programs. Prior to this year, in 2021, it's just in, I think, June of 2021, where we started to contract with residential programs. There were simply arrangements to take children, but there was no way to hold them accountable for the quality and effectiveness of the programs that they provided to children. So the state is on the move to provide really good, effective, evidence-based programs to treat children and to get them in and out of the system as fast as possible with as least expense. But the focus thus far has been on this deep end where children are already, quite frankly, damaged. And if we can intervene earlier in those years from 0 to 8, you're going to see far better, more lasting outcomes with them. So this bill is actually, unfortunately, should have been presented 6 years ago. And if we'd done that, we would have already seen this cascade of improvements and fewer children coming into the system. In other states where they have these kinds of programs, like New Jersey is one, they have actually closed most of their residential programs. All of their children are being served in the community through really preventative behavioral supporting programs, so that imagine the amount of money that the state is saving, because they're not waiting for the deep end services for children who already have considered disability and interruption of their development. So I appreciate the question. I think it's a really important point.
Thank you.
Okay, thank you very much.
Thank you very much.
Mr. Williams, how are you today?
Senator Bradley, thank you so much. I would like to invite up Director Rebekah Ross. It's great to be able to call her director in addition to an attorney. Rebekah Ross, I've had the privilege of working with her for years. And also I'd like if we could also, as a resource, administrator who is our legislative liaison for Division for Bureau of Behavioral Health. And this is Ms. Jamie Higgins, who will introduce themselves for the records and will do our best to answer questions.
Good morning, members of the committee. Again, for the record, I'm Rebekah Ross. I am the new director of the Bureau of Children's Behavioral Health. I started on Friday, so I will
welcome.
do my best, thank you, to answer your questions and go back and get whatever information I don't have. I have been before you in the past as General Counsel and Legislative Liaison for the Division for Children, Youth, and Families, so I do have some experience with the overlapping programs and services, but if I don't have the information, I assure you I will go back and get it for you.
And also for the record, I'm Jenny O'Higgins. I'm a senior policy analyst and legislative liaison for the Division for Behavioral Health. Happy to answer any questions.
So I'm going to start right out. The department didn't sign up, didn't take a position on the bill. Can you sort of outline for us how this would function and within some of the existing programs that you have right now?
Yes, so I will do my best. I can provide additional information as needed. The elements of this are consistent with the system of care and the 10-year mental health plan, and it's my understanding that these would primarily require amendments to contracts and the agreement of our current providers to expand their services that they are currently providing. We did receive ARPA approval for $1.6 million on the ACEs portion of the bill. I don't have the full details of that. That was approved
Through the fiscal committee?
Through the fiscal committee. I believe it was in November, and that was fiscal item 21355. So there is an intersection of that initiative to secure funding for the early supports and services that is in parallel with this bill. So we can work out further details of what exactly that's including in this bill.
And if I could, go to the fiscal note. So some of the services that fiscal approved are covered in the fiscal note?
Yes. I don't know, Jenny, do you have more information?
Well, what we had written into the fiscal note is the piece that was approved by the current funding for ARPA. So the sections of this bill that were not in our initial request are something that we could work with on the sponsor on adding, but they're that are not currently funded.
And I think you said it was 1.6 million?
Yes.
Okay.
If you look on page 3, line 11. That's the appropriation that I believe we will need to fiddle with. And we could do that in conjunction with the necessary appropriation for section 11 in the amendment. So we could do that together. Would that work? Yeah.
Yes, what I just don't know is the exact one-to-one correlation and what's included in each, so I want to make sure I have the details on that before I say exactly how those would interact.
Perfect. We can, yeah.
Okay. Any other questions? Yes.
I just wanted to, I mean, Attorney Ross is very humble, but she does know these programs very well. She was very much involved in Senate Bill 14, the development of the bill, the passage of the bill, the implementation of the bill. So certainly she does have a lot of experience, and I thank her for that work and that, and look forward to working together on implementation of this part of the bill. So thanks.
Thank you.
So, I learned to my rue when I had a LSR that dealt with some of the environmental issues that we're using ARPA funds to fund, that it was recommended to me I withdraw the LSR and work through the fiscal committee process on some of the environmental state park things. So my question to the department is, on some of these items that are outlined in Senator Whitley's bill, which makes sense to me, are you working through the fiscal committee process right now to fund them using ARPA funds?
With the exception of those ARPA funds that have already been approved,
Yes.
I'm not sure. I have to go back and get that
Okay.
information. I also think that there are things in this bill that we would still be looking for the statutory authority and the directive from the legislature to move forward on, even if we're securing the funds from the other avenue.
Okay. All right, so are there any further questions of Ms. Ross? And congratulations.
Thank you very much, Senator.
All right, so before I close the hearing, this is what I'm going to recommend. As I said, virtually all the ARPA funding is going through fiscal. I think what would be best is with the child advocate, with the department, with the sponsor, to work with the department in terms of trying to appropriate some or all of this money through fiscal. It will happen sooner if you can convince them. And as Ms. Ross just said, the portions of the bill that need legislative authorization, then we could proceed with. Does that make sense to you, Senator Whitley?
It does. So, you know, it does. What we could do, because there's a lot of policy attached to this, it's not just appropriations.
I get that,
So
but you know what's gonna.
Yeah, no, I get it. So I'm just wondering if this committee wants to just pass the policy portion, we could even take out the appropriation section. I mean, we could do it different ways. I don't want to stall on this because I think this is as a package of policy is super important for the legislature to weigh in on. So I don't want to, you know,
I would
not
be
do that.
comfortable with that, but I also feel like, given that we're trying to create, you know, all the things around Senate Bill 6 and Senate Bill 14 from a couple of years ago and the 10-year mental health plan, that before we take action on the bill, I'd like to see you and Ms. O'Neill and the department, Ms. Ross, you know, get back to us in the next couple of weeks on where you might be with fiscal. Okay, does that make sense? And then I think it's a good idea to adopt the policy without necessarily the appropriation. Does that make sense to everybody?
A third path, sort of in the middle, is that we could pass the policy and then the department and I can work with the finance committee on addressing.
That would be a third path.
We like options.
I would like to think it over.
Well, we're not going to take any action today, so in any case. Okay, I'm gonna close the hearing on 444. And open the last hearing of the day. On the Prescription Drug Affordability Board. We kind of have a deadline of 12:30 to be out of here, so I would just hope everybody can do well within that time constraint. Senator Sherman.
Thank you, Mr. Chair. I am, for the record, Senator Tom Sherman, District 24, here to introduce SB 450 relative to the Prescription Drug Affordability Board. As you are aware, in the 2019, we created the Prescription Drug Affordability Board. It's a fairly complex endeavor, and while we made every effort to make sure that we had put in all the necessary bells and whistles along the way in the under the leadership of Chairman Merchant, and I'm one of the members of the board, we have found that there needs to be significant changes to really make it more workable. Some of these are being addressed in a House bill, but what we found was that after the House filing period had closed, we had hoped to have just one bill do it. There were additional tweaks that needed to be made, and so I introduced this bill to make those changes. And walking through the bill, you'll see the membership in line 20. Actually, the changes in the first three, which is A, B, and C, refer to D, and D allows the flexibility of having any alternate serving in the place of any absent member at the discretion of the chair for the purpose of meeting the quorum. And what this is really for clarifying purposes, to make sure that the alternates can be nimble and available. Especially with COVID, we've had problems with having the actual member able to attend. The alternate member may or may not be able to fill their space, but the actual process of being able to say, yes, this person can come in and serve in that role has been a little more cumbersome. So this clarifies that. The second part is to bring conflicts of interest into, to standardize those with what's already in statute. So in the original bill, you'll see the language that's crossed out, lines 24 through 26, and it links this to RSA 15B. RSA 15B is the section of statute that talks about gifts, honorariums, and expense reimbursements. So this is the standard statutory language, and rather than having something new and different, we're just going to the standard for conflicts of interest. And then the last one in part 3, lines 5 through 7, there was an entire group of people who had been excluded from the original bill, but rather than saying this whole group, which I believe was wholesalers, no, it wasn't wholesalers, it was, I'm trying to remember which group. Do you remember?
The problem with the PBMs was the fact that some
were just doing claim processing, some were doing a full benefit package. What happened was there's no way for the board to determine which one is doing what. So to standardize across the PBM world, we basically said if you're doing
You know
that.
what,
Do you want him to come join me?
You signed up to testify. Why don't?
Okay, I'll defer
Yeah.
to Representative Merchant on that one. But rather than put in the entire class, which would have included more people than would have been appropriate, we put in the function that they do so that a subgroup of that class would be identified as needing to participate.
Okay.
And that was the last part.
Questions of Senator Sherman? Certainly sections 1 and 2 look pretty straightforward. We'll let Representative Merchant explain section 3. Senator Gray.
Line 20, page 1, where you start talking about the alternates. I'm familiar with places in the statute where we go in and say a particular department may have an alternate, or that may be, at the discretion of the division or whatever. But this kind of says to me that I can have this list of alternates sitting out here, and the chair gets to pick from that list and not the, replacing the person who is not there.
We have, alternates are identified in the statute. And actually you can see those up above in A, B, and C. What we found is that the alternates are tracking along the function of the board. They are understanding what we are doing so they can actually step in and serve. But we may have one alternate who can't be there, but we have another alternate who can. So if we have specific assigned alternates, then we don't have the flexibility to reach quorum. So, for example, in A, there's one alternate member. B, there's one alternate member. And in C, there is another alternate member. All three, if I'm not able to participate, or if Senator Carson, who's on the board, can't participate, Senator Rosenwald is the alternate that was appointed by the President of the Senate. If Senator Rosenwald is not there, there is another alternate who could be there. It's just not that particular one. So in a way, you're correct, but it's not a huge list. There's only 3.
Follow up?
Yep.
I think you're getting to my point, is that now the chair has the ability to affect the outcome of that commission far beyond what I would be comfortable with by saying, okay, Carson can't be there, so I'm going to pick somebody from whatever, and I don't think that that's appropriate.
Yes, if I understand what you're getting at, and if it would help, you could prioritize your alternates based on the alternate that is assigned. So, for example, if Senator Carson's alternate, which would be Senator Rosenwald, is not able to attend, then it could automatically go, then the chair would be able to choose from the remaining alternates, but the first priority alternate would be the one that's assigned. The problem is it's a small board, small number of alternates. Everybody is deeply engaged, but we really need to be able to reach quorum. And these are not, by the way, these are not necessarily House members or Senate members that are appointed. They can be from any walk of life. So the Senate president could choose a pharmacist who is retired that they happen to know from Salem, and that person could serve in that. So these are not necessarily senators or representatives, and in fact, it was not intended that they necessarily would be.
Talk more when we get to that.
Okay, thank you very much.
Yep.
Seeing no further questions. Representative Merchant. My wingman.
Good morning, Mr. Chairman. I've asked Attorney Berry to be with me as well. He has been our right-hand person on the board as far as our link to the Department of Health and Human Services. We're administratively attached to that organization, but we are an independent organization on its own. But Attorney Berry has been very helpful in trying to navigate some of the things that we're talking about today. So if I get myself into too deep, he's going to pull me out. So I did provide written testimony, not to go through and belabor the whole thing. You can read about this later. But the three things that we basically trying to accomplish within SB 450, as Senator Sherman said, basically, when you get to the alternate centigrade, we only have 8 members on the board. There is a very small select group of people. The reality is, to be on the board does not require you to be in the legislative, either in the Senate or the House. That was actually by accident that happened that way. Representative Murphy was actually appointed to the board, who was an orthopedic physician, prior to him becoming a member of the House. We have Attorney Fahey from AARP, who's not part of the legislative process. We have pharmacist Herman. The challenge you run into is that because at this particular point in time, with people's schedules being what they are, typically being in the House and the Senate, this very active time of the year, it's hard for us to get a quorum. So by giving the flexibility to the chair amongst the very handful of people who are involved with it as much as they possibly can, to at least meet the quorum. That's kind of the intent behind it. The other one was the fact is this all came to us during our meetings during 2021, and you want to see the annual report, we're more than glad to send it to you from the board itself. The conflict of interest, I think, is straightforward. Basically, we're trying to standardize to what we have today in the Senate and also in the House and other things. It's basically at that point in time is let's use what's there now and not create another one, which is a burden not only to the Secretary of State, but also to the board and other people. The third one came down to the issue of categories of entities that we have assessment fees. This board is self-funded. It's not supported by the state. It does come out of general funds. It's supported by assessment fees, the different parts of the pharmacy supply chain, from manufacturers, wholesalers, PBMs, and some insurance companies, depending upon how they interact with the pharmacy supply chain. So it's self-supported. However, in determining certain things, there was sort of a quirk in what we looked at with PBMs, and it became looking at, we were trying to define the PBM based upon their function versus their status. And some PBMs provide claim processing, pay bills. They also provide a drug benefit. And sometimes they provide all three to different entities depending upon what the entity wants to acquire from the PBM. So to minimize the confusion, we basically at that point in time chose to say if you're a PBM, you're all in the same bucket and not try to figure out which one's playing with what. Since I worked with Senator Sherman on the board, one of the things that also came to light, when we started asking people to register with the board, what we found out was the terminology is somewhat different. And what I mean by that is you have entities out there that basically take a large bucket of pills, 55-gallon drum, if you will, and put them in the smaller containers. They put their own label on it, their own drug code, and they set the price for it. But they're really repackaging the drug. If you go back into the statute, it says they're exempt. And I think what we want to be sure of with this board is should hold them accountable to the board about price increases. So I would suggest to the board that we also modify after, if you go back to Senator Sherman's bill, on line 2, page 2, line 7, that we insert a simple phrase that says, and includes any packager, relabeler, labeler, or repackager that sets or controls the price of a drug sold in a commercial marketplace. If all they're doing is providing a service, they're not putting their label on it, not controlling the price, they should be exempt. But if they're setting the price, they shouldn't be. So by clarifying it that way, we're not allowing them the ability to use what's in the statute, the phrase repackager, to exclude themselves from the intent of the law was price notification. We're trying to inform the public about what's going on and what pharmaceutical prices. We know today they're very, very expensive, and we're trying to find ways to collect as much data from all the people who set the prices as we possibly can. That's basically the intent of the bill, I think, Senator Sherman. I'll be more than glad to answer any questions. It's been a lot of work. I want to again commend Attorney Berry. He's been very instrumental to the board in helping us navigate a lot of things. Without his help and some of the other folks in the Department of Health and Human Services, we would not have accomplished anywhere what we've accomplished. And I'm really proud of the board. We've been around for less than a year. And my colleagues in other states have created such boards who have a year or two above us. We are doing more than they are and accomplished more than they have. But I will go back to is because of the staff we have to support us. And I'll take questions.
Questions of Representative Merchant or Mr. Berry? Okay, seeing none, I think no one else has signed up to speak. So here's what I would suggest about this. I think Senator Gray has made a good point. I didn't quite pick up on it, but he's right. I don't think the Senate would want a House member replacing a Senate alternate. I doubt the House would like a Senate member replacing a House alternate. So my suggestion would be if more alternates are needed, fix the appointment of alternates.
So increase the number of.
I would increase the number of alternates.
We can do that.
Okay.
Just reminder though, they don't have to be, oh, sorry. They don't have to be actual members of the chamber. So the actual description of the choice, let me see if it's in this. I don't have the underlying statute available, but they.
Well, it's right there.
Yeah,
the
there it is.
President of the
Okay.
Senate shall also appoint one alternate board member.
So we could do 2.
You could do 2. I think most people would read that to mean 2 senators. If you mean the Senate President can appoint non-senator alternates, or the Speaker the same thing, you should say that also.
Okay.
Because I don't read it that way.
Okay, so the description up in lines 3 through 7 is what we were looking for, and we can I can clarify that in an amendment. But the description does not require that it's a member of the Senate. So I'll make sure, or the House.
I think you better clarify that.
Yep.
Senator Gray.
And since a quorum, I'm presuming, is 3, since you've got a 5-member board, if you don't have a quorum, you are going to have one of these groups not represented because you're only going to have 2 people. Okay? So if all 3 groups are represented, you've got 3 people. You've got a quorum. So what is a quorum then, sir?
If I may, you raise a good point, Senator. Just based upon the math of what we have, there are 2 appointed by the Senate, 2 appointed by the House, and 1 by the governor. If we have 1 from the governor and 2 from the House, and we don't have a senator, we still have a quorum. And the intent of this, I believe, was not to have legislators on it. It happened by accident that way. And I'm trying to, I think we're conflating the issue of legislation or legislators versus board members, like the Board of Pharmacy, for instance. We don't have legislators normally on a board of pharmacy or a board of nursing. It was more of a fluke.
Follow up?
Yep.
My point is that the Senate President may appoint certain people based on his philosophy. Okay? The Speaker of the House may appoint certain people because of his philosophy. And because a quorum is only 3, okay? One of your groups, if you are lacking a quorum and you can't fulfill it with the alternates that as they're described now, one of those groups will not be represented. Either the governor, the Senate, or the House. And I can't go there. Thank you.
I think the solution is that we increase the number of alternates. And we'll also clarify that they don't have to be members of the legislature in the amendment.
I'd recommend you work with Senator Gray. Make sure he's on board.
Increasing the number of alternates is a fine solution for me.
Okay.
Because again, you know, we're going to have a quorum. I want to make sure that all 3 groups are represented as best I can.
Okay, we'll get it drafted.
Okey doke. I'm going to close the hearing on Senate Bill 450. I think we're done for the day. So next week, again with apologies, we're meeting 2 days, and probably the week after if we can. So expect any day we don't have a session to meet Thursdays as well as Wednesdays. All right, motion to adjourn? All in favor, say aye. Okay, thank you.